Thank you for joining us today. One of the things that Brattleboro Memorial Hospital is constantly working on over the years is working on quality improvement and trying to figure out what makes a hospital successful and constantly raise the bar as hospitals around Vermont and across the nation do the same. Michele Rowland is the Director of Quality and Care Management at BMH. Thank you for joining us.
Very welcome. Nice to be here.
Well, it's funny. I know when I'm not doing a good job, my boss would come and yell at me. Now, how does that relate to how a hospital knows whether it's doing a good job?
We have several ways to know. We are always actively involved in seeking input from patients and families about their experience at the hospital. We employ a company called Press Ganey and send out surveys after people are seen in our emergency department, after they come and are admitted to the hospital, and we're requesting what their experience was, and we ask for actual recommendations for changes in our care. Another way is we have outcomes. We look at statistics and data and benchmark our results against national and regional data elements. So we know, survival, readmission rates. We know things like infection rates, complications. And the federal government has continued to add new data elements that we must publicly report. But I think at Brattleboro Hospital, what is one of our has always been one of our initiatives is that we're always looking at ways to improve the quality of care. And it's not simply because somebody is looking over our shoulder or asking us to do that. We have, I think, an exemplary group of professionals, nursing and physician, and that we're always looking at ways to improve the scope of care, the complexity of services we offer, and also the quality, and have improved outcomes.
I had a relative once who said, I never want to go to the hospital because that's where the sick people are. Granted that, hospitals are where you do things like treat illnesses, treat infections. How much of those do you find are inadvertently spread to either patients or staff members, and what do you do to minimize them?
Mm-hmm. Well, we even have a term for it in medical care right now. We call any acquired condition that occurs while a patient is in the hospital iatrogenic or hospital acquired. And we're forever watching and looking at that. We have enhanced surveillance for things like infections that occur after after a surgical procedure. We look at things like central line associated infections. So when somebody has a central line that's being threaded in to one of the major veins, we're looking at, are they getting infections from that? We look at how many times we place a Foley catheter, which we need to do to drain somebody's bladder. How many times has that now resulted in an infection? An important initiative that we just are kind of finalizing its final phase is we're looking at things like delirium, the occurrence of delirium in the elderly, which is a common and really little recognized iatrogenic condition for older adults, usually people 65 and older. And we're looking at those outcomes. What happens when a patient comes to the hospital? What can we do to prevent its occurrence? And why? And it is kind of confusing for patients when you think of where in a healing profession we want to improve patients' current status, how these sometimes negative things can occur. So we're always looking at processes to improve so we don't have those issues happening for our patients.
So that's why when I go to the hospital, nurses and doctors are always asking me, what is your name? What's your date of birth?
Yes.
Do you know what day it is?
That's right. That's right. We have standardized instruments that because one of the biggest risk factors for the development of delirium is any kind of cognitive impairment, pre-existing dementia, memory cognitive limitation. So we are asking standardized questions to be able to determine what's the patient's baseline functioning. So we're able to then assess, is there any change? Have they, has their mental capacity been affected by the hospitalization, combination of meds, any of the above? So that's why we ask those questions. When we're asking that question, or a series of questions before we, as nurses, give a medication, it's to make sure you're the right patient, we're giving you the right drug at the right time, at the right dose. We want to make sure that there's no complication in that regard. So yeah, we ask people to bear with us as we ask those questions over and over again.
Well, it does make a lot of sense. You certainly want to be sure, because when you're working to improve a patient's health, you always want to make sure there is no margin for error.
That's right. And it's a complex business we're in. It's multiple people providing multiple services to one patient. So I think one of the most interesting kind of movements that are happening currently in healthcare is the whole consumer movement, having people become much more informed about their medications, about their disease process, where they are in the disease trajectory, and having them be active partners in not only some acute phase like a hospitalization, but in their whole management of their disease or illness.
That may be good and it may not be so good. I mean, I think Wikipedia is a blessing and a curse to us all. Someone would go to their doctors thinking they have a weird disease or a weird symptom, and it just might be related to something else. A lot of different things come into play. How much can a person take ownership of his or her health?
Right. Well, we're not asking patients to self-diagnose. We're not asking them to, do some research and come back to us with what you think you've got. We're making the diagnosis, and once we have confirmatory evidence about what a patient may have, a new diagnosis of diabetes or heart disease or maybe a cognitive or memory issue, once they've given that diagnosis, it's essential that we not just talk at patients and tell them what's going on, but really elicit from them what they understand about the disease. Because for so long, physicians thought, I told that patient they had to lose weight. I told them they had to stop smoking. But outcomes proved that simply telling a patient does not result in that change in behavior. So it's essential that is a dialogue that takes place and that the patient really understands this is what you have. Your choice is to participate at this level or not, but these are the outcomes. If you do nothing, if you do 10% of our recommendations, or if you decide to be 100% on board, these are the outcomes that you can realize. So it's a partnership, not an abdication of responsibility, having the patient, research and come back with what they think the med is that they should be on.
How much does the insurance industry and really the work to hold down insurance costs come into play? For instance, there might be insurance plans who would say, we'll pay for X number of days of hospital stay if you have this procedure done, etc. But everybody's different. So how do you work all that?
That's another aspect of my job, utilization, and the whole issue regarding quality of care and are we meeting the recommendations of a particular healthcare plan. Patient comes into the hospital and one insurance carrier will pay for it at this rate, another one would pay for it at another rate. So I'm vigilant to make sure that the patient, when they're coming to the hospital, we've done those pre-certifications, that we're aware of what their plan provides, whether it's Medicare, a publicly funded program, or it's a commercial plan, what is provided. And I think it's foolhardy not to be informed, because the idea that, it doesn't really matter or it doesn't play into patient care is not true. We are needing to be vigilant of cost and what is, kind of a judicious use of what is really limited healthcare resources. But we never turn a patient away for their lack of ability to pay. If they cannot pay, they do not have resources, my group will turn over every stone in order to get somebody the care that they need. And not just in the acute care setting, but also when they return to the community, getting the medications through the drug companies themselves or getting an agency to provide free services. So we need to be informed, and we need to also, again, talk to the patient about how we can look at any potential resources that they may be eligible for.
I'm glad you mentioned that, because there might be a perception out there that once someone is discharged from a hospital, that's it, But that's not the case.
Yeah, and I think that's been a change. It's been an evolution over time. One of the initiatives from IHI, which is one of the quality organizations, the Institute of Healthcare Improvement, one of their big initiatives over the past 2 years has been what's called care transitions. There's no longer a discharge. There's no longer a patient just leaving an institution and that being the end of the story, the final chapter. They've had institutions and providers start looking at it in a very different way, that it is a continuum. That patient isn't going anywhere. They're just now getting their services and care in another venue. So what we now have done is put in a number of different initiatives to ease that transition and really see that just as part of the trajectory. We make sure that patients have follow-up appointments with primary care. We make sure that the patient has an understanding of their disease. We make certain that that patient has access to the prescribed medications, because for so long you would write the prescriptions and the patient was all set. And how many times did we call 2 or 3 days later and find that the patient, didn't have a ride? Oh, I was waiting for my check to come in next month, not understanding the importance of continuing what we started as an inpatient. So there is no discharges. It really is part of a continuum. And we have recently begun a post-acute program. Dr. Carolyn Taylor Olson has now taken on a role where she will be serving as the medical director for all our skilled and nursing homes in the area. And she will provide that care and be part of the inpatient treatment team to help ease that transition to that next step, that next facility.
That's interesting because there is a push by some in the state of Vermont to make sure that if you wish, you're able to stay in your own home until you die or until you are close to it. There's still room in the continuum of care for nursing homes, for assisted living, those sorts of things?
There is. I think it is folly to think that one size fits all, that we don't need nursing homes anymore. We don't need skilled facilities. Maybe we don't need small community hospitals. I think that is not well informed, that we need to look at individuals. We need to look at what patients bring to the table, what they have as resources. And I am in, support of that program. There is a wonderful initiative to have people, it's called Aging in Place, having them stay in the community. And it is both a cost savings, but also an improvement in quality of life for many patients. They can stay in the home that, they've raised their children in and they've lived in for 50 years. But it's not well advised to think that that is for every patient, because some patients, the complexity of their needs, geographic isolation or whatever, they're not able to be maintained in their home safely. So it's great to have an array of services, and that's what my group, the care management group at the hospital, does, is looking at what patients are able to provide, what families is able to provide, what is their existing resources, and try to find the best match for the patient and the family.
What kind of systems are in place to make sure that BMH and other facilities know what kinds of care they're best suited to provide, and that they have the systems, both the equipment and the professionals in place to do a good job?
Well, my group, again, we are, from the very first time the patient presents to the hospital, we will see a patient in the emergency department. We see people on referral from their primary care doc. They do not need to be inpatients. We're happy to take telephone calls from patients or families asking about what is available, what are resources, and then looking at, again, all that kind of complementary issues. What is their insurance carrier? Where do they live? What is their complex needs? We're able to give them an array of choices that they're able to pick from regarding, placement if they need a out-of-home placement, services, durable medical equipment. We're able to kind of give them those choices and help them to facilitate accessing them.
And given that, at what point do you say, well, this might be something better suited for a facility like Fletcher Allen or Dartmouth Hitchcock?
We have great referral relationships with all our tertiary care facilities. Bay State is another one. We work very closely with Dartmouth. Without question, that is our primary referral source. And we are ever vigilant for finding to look at when a patient's care just becomes too complex. We can't be all things to all people. We don't have the array of services that an academic medical center does have. We're able to provide a lot of care and a lot of services, but not everything. So the physician every single day is evaluating that patient, sometimes multiple times in a day, and evaluating, is that patient's condition improving over time, or is the complexity just too great and their status just too grave that we need to facilitate a transfer. And so we do that. We are very vigilant and quick to get available services and have people transferred, whether it's by ground or by helicopter, to the tertiary care facilities.
And how quickly can that sort of thing be done? Because there's all kinds of studies that say you have to make sure you have a certain kind of treatment within a certain amount of time to guarantee a better outcome. And even this week, Dartmouth Hitchcock just put out a study that said if you have more neurosurgeons within a certain radius of where you live, you have a better chance of surviving an accident.
It's true. That is true. A lot of that work was done by John Winberg, who heads up the Dartmouth Institute, looking at available resources and then what is the outcomes. They've done studies too with looking at premature infants, the same thing, birth and what then is the outcome for those babies with those resources. I think we try to do it in the most timely way. It takes just a matter of hours from identifying that new problem or worsening condition to get that person transferred up. And I think there is a place for community hospitals. I think community hospitals provide timely and efficient care, and that negotiation and that communication with tertiary care has only increased over time. We had been talking earlier about Valley Regional. They were the first hospital in the country to develop telemedicine. And that seems like, an old idea, but it's particularly in rural areas, has seen a real resurgence. That a physician in a remote location can do a neurological exam on a patient and determine their likelihood of being able to receive specific medication to treat a stroke. And those kind of resources will only increase over time because the need for community hospitals is there, but we also need the backup of tertiary care hospitals.
So given all of that, Michele, how is BMH doing? I mean, how do we compare with, say, your average community hospital in a rural setting?
We have done very well recently on some objective outcome measures. We recently received an A from the Leapfrog Group, which is a group of healthcare professionals, insurance providers, employers, and consumers. They looked at a variety of data elements, outcomes, some publicly reported, some safety and outcome measures, and we received an A, which we were very proud of. Recently in Consumer Report, we got a great grade. We got a grade of 73, and that was reflective of a number of different, again, data elements, safety, some publicly reported data elements, such as core measures, as well as patient satisfaction information. So I think we're holding our own, and as I say, we're always vigilant, looking at ways to improve, and in no way looking at some of the scores that may have been provided to our area facilities as being statements that those aren't safe facilities, because they are. It's a complex business we're in, and the data and how it's looked at and parsed is also how the information can be kind of interpreted and misconstrued at times.
So it's your feeling then that nearly all of the area hospitals are doing a good job?
I think so. I mean, I feel personally and professionally that we would not refer to facilities that we believe would be providing substandard care. And I think that it's important to recognize the complexity of the business we're in. It's tough work we do. And that I believe that everybody has, really committed to doing the best for their patient population. And that is different depending on, geography and patient need. But I think everybody is, understanding the importance of our role and the job that we have ahead.
Change is on the horizon
you
in
think?
the healthcare industry.
You think?
Yeah, the tremors are being felt as we speak.
Yep.
Given that, what kinds of new demands do you see being put in place for your industry, and will the bar be going up on outcomes?
Yeah. Without question, there's going to be more publicly reported outcomes for us. And I think that, and I'm old, I thought I would start my career and end my career never touching a computer. That has not come to fruition. I think the most, kind of dramatic change in the delivery healthcare has been, computerization, electronic health records, the delivery of, information to be transmitted across the country. That whole array of demands and also successes is going to challenge small little hospitals. It's something that we need to keep pace with. We're part of a Meaningful Use initiative, which is an initiative established by the federal government to have small hospitals, community hospitals, as well as small critical access hospitals, develop electronic medical records and actually have those electronic medical records integrate. And that's the big demand and the big push and challenge ahead, is to have not just information, but information that is going to be available in a timely way to positively affect how the care is delivered for a patient and ultimately the outcome.
One of the big juggling matches is trying to make sure you keep the small nature that is so attractive, but deal with the economy of scale. I mean, Vermont is the size of a fairly significant sized city. By comparison, you've got 14, 15 hospitals.
I think it's 14, right? 14 medical hospitals, right? Yep. But that small size provides us a lot of advantages. The CDC, there's a wonderful initiative that we've recently been engaged in. Jan Pachowski, who's our Director of Safety, Infection Control, and Credentialing, was part of an initiative. The CDC actually contacted healthcare facilities in Vermont and wanted to look at, was there initiatives in a small circumscribed area, geographic area, were there initiatives that we could be part of to prevent the transmission of multiple drug-resistant organisms, what's called MDROs, and it's things like MRSA that people have been hearing about, methicillin-resistant Staph aureus, C. diff, C. difficile. But they came specifically to this state and the state alone to look at, because there are a limited number of providers, could we develop relationships with our referral sources, not just working with the hospitals, but looking at residential care facilities, looking at skilled facilities and nursing homes. Could we work together to develop actual initiatives and programs to prevent this multiple drug resistance? And there were several suggestions that came out of it. Our group was called the Brattleboro cluster. Several initiatives came out of that. Things like, antibiotic stewardship, stopping antibiotics if somebody did not have an infection, making sure that we're adhering to something simple as hand washing, communicating, again, that information across the continuum. Does that nursing home know when we send that patient back or send them as a new patient? Do they know this person has had this infection and what they need to do to prevent now another patient developing an infection because of that cross-contamination? And then another initiative is the issue of patients often are carriers. They're colonized with these organisms and don't know it. So sometimes we'll be talking to patients and families about somebody being a carrier or being colonized with a bacteria, and that we're now going to try to eradicate that so they do not now transmit that to other patients. And although it is sometimes shocking news, it's essential news because, again, it's preventing an iatrogenic condition, something that we can prevent by sometimes just simple initiatives, simple interventions.
Where can people go to find out the kind of information that they would like to see about how their local community hospital is doing? And again, how can they be a part in making sure that quality and outcomes continually rise?
Mm-hmm. Couple places. The first, if they're looking to just look online and start comparing hospitals, our hospital compared to other hospitals, the federal government has put a website together that has several, and it will be a growing amount of data elements. It's called Hospital Compare, and it's at Health and Human Services, hhs.gov. That's a program that was developed by the federal government to make consumers more informed and to have them understand what the rankings were of their community hospitals. Personally, patients need to ask questions. They come to the hospital, they're in their physician's office. It's really essential that they're asking questions about things like, what are infection rates? What are mortality rates? What are readmission rates? And I have those numbers and be happy to share them, but physicians will have those numbers and be able to inform patients about that, because it is reflective of a hospital's vigilance and attention to those issues, which are really essential for healthcare decision making.
I'm glad to know that. Michele, how can people get a hold of you if they have further questions?
You can reach me at the hospital. Dial the main number and just page me. I'm rarely at my desk, as people will tell you, but I am able to be reached by just being paged by the main number at the hospital.
Well, it's been a pleasure having this conversation. I've learned a lot, and hopefully our viewers have as well.
Oh, thanks so much, Tim.
You're very welcome. Our guest again, Michele Rowland, who is the Director of Quality and Care Management at Brattleboro Memorial Hospital. As healthcare changes, it's up to you and I to be better informed consumers, and that will have a better effect on our own care and the care of our community members. Thank you very much for watching.